Hi, everyone. Welcome to a live chat with Nurse Linda. Linda Schultz is a leader and provider of rehabilitation nursing for over 30 years and a friend of the Christopher Dana Reeve Foundation for close to 2 decades. Now I'm going to turn it over to Linda. Hi, Linda.
Hi, and hello, everyone. It's always nice to be with you. This is my favorite day of the month when we get to do the webinar because it's always nice to find out what's going on in the community. And this is a good way to get a good national and even sometimes international point of view of what's going on. So I just wanted to open a little bit and talk about the COVID. We're going to talk a little bit more today about autonomic dysreflexia and pain. But let's start with the COVID because, oh my, hasn't this been going on for a long time? And I'm sure you are like me where we're ready to be out of the house and kind of starting to go back into life again. But I don't know, where exactly you are living and what the circumstances are where you are. But where I'm living is one of the 10 cities in the United States that has been designated as the absolute worst for controlling the coronavirus. And I'm just like, oh, really? Seriously? But so we've been put back into quarantine as of last Friday. And it was very disappointing because I was thinking, well, gee, maybe I could get out and start doing a few things, and a lot of moderation and a lot of controlled circumstances. But I thought I'd like to see some of my friends in person, and I'd like to just kind of move about. Heck, I just even want to go to the store and pick up a few items. And it's funny what you miss when you don't have it anymore. Going to the grocery store was the bane of my existence, and now I can hardly wait to get there. But fortunately, the delivery service and my neighbors have been taking good care of me, so I hope that you are getting as much help as you need as well. So we have to maintain ourselves, keep strong, keep positive. It's a long time that this has been going on, and apparently it's going to go on longer for some of us. The viral load especially up in the northeastern part of our country, is way down, and that's around the New York area and the other states around New York who've really done a terrific job in containing the virus. Now, it's not completely contained. It's still out there. And so, you have to think about, there are all these rules about, don't collect in groups of more than 10 people, and then it went to 50 people, and there's social distancing and hand washing. That is going to be imperative probably from here on out. That probably the social distancing and the hand washing might not ever go away, certainly the hand washing and maybe even the mask wearing. We'll just have to see how that goes. But the issue is that when you encounter someone, it only takes that one person who's carrying the virus, and then whoops, all of a sudden, there it is. So I have some good friends, a gentleman and his wife that both got it by going to a socially distant outside in the park event, and they both came home and they had the virus. And he is undergoing chemotherapy, and so he had to stop taking his chemotherapy. And so I think there's some feedback or something going on. Sorry for that. And so it's been kind of tough on him because he's ready to conclude his treatments because he's close to the end of that. But in the meantime, now the rules have changed, and he was to have 2 negative tests, and now he doesn't even have to have a negative test, but he can have the chemotherapy. I think that's another hard part of this is that the rules are constantly changing, and indeed they truly are. So sometimes I'll be writing a blog about COVID, and it's not going to be posted for a week or two, but I'm writing it, and even in the middle of writing the blog, there'll be some news flash that comes across the TV. Oh, wait a minute, this has now changed. So it's very hard to keep up with all these rules and regulations, but just keep yourself safe, keep your distance, keep washing your hands, all that sort of thing. If there's actually a question that pertains to this, so before we move on, let's hit this question. Because it says, I have an aide who comes in for several hours every morning. What precautions besides masks should I put into place? Well, this is really quite an issue because you don't know where that aide has been or how they've been engaging their life. Do they go out a lot of places? Here where I live, we have a lot of people who go out without masks, without being socially distanced. It's called the brews and cruise. So they go out drinking and cruising. I don't know. They call it the brews and cruise. So I guess that is pretty descriptive of it. So if your aide is engaging in that kind of activity, you probably maybe even want to try to look for somebody else or get a substitute, because that means they could have a lot of exposure. If they're a family person and they're engaging with their family, they're being socially distant when they go out of the house, and they're wearing protective covering when they go out, you're probably okay. When they do come into your house, you want them to have a mask on. The mask is really a protection from somebody from giving you the virus. So if the virus is out there, the masks are helpful to try to keep the virus out of your respiratory system. But remember, that virus is very teeny tiny, so it can slip through a lot of little weaves in your mask. So for the person who's coming to your house, it's a good idea that they do careful hand washing when they come into your house, going all the way up their arms, up, maybe to the elbow, because they'll probably be touching you in that way. And wash their hands frequently while they're there. They should be wearing a mask. If you choose to wear a mask, that's fine. If you have breathing difficulties, which a lot of people with spinal cord injury have a difficult time breathing, or might have more challenges to the respiratory system, so you should decide if it's comfortable for you to wear a mask or not. If you're having trouble breathing, you'll need to take that mask off so you can get some air into your lungs. And you want to be sure that carbon dioxide isn't building up within your mask. So if that person is away from you 6 feet or so, you could maybe take the mask off for a while off yourself. But the person coming to your house should always have a mask on. They should always be doing hand hygiene. In the extreme, when it was really bad, and if you're living like where I'm living in one of the top 10 cities for the COVID that's yet uncontained and the cases are going through the roof, you might want to have them come in and bring clean clothes in a Ziploc bag so they're not contaminated, and change their clothes when they come in. So try to be as cautious, as careful as you possibly can. Wipe down your counters, your surfaces, doorknobs, anything that person might be touching, in case they've carried the virus into your house. So those are some of the things that we were having. Oh, and also have them change their shoes. So have them bring a pair of shoes, or leave, if the person is coming every morning, to leave a clean pair of shoes in your house so that they can change their shoes when they come in, and not, because these viruses, gravity, we have gravity, so they drop to the ground. So where you're walking is a pretty dirty place as far as bacteria and viruses go. So those are some things to think about. Another question is that I'm going to an outdoor wedding in 1 month. What can I do to protect myself? Well, I hope you're going to a place where people have been self-isolating. And if it's outdoors, that's better, because you have more air currents around you, which can carry the virus away from you, but can also carry the virus towards you. So maintain that social distance. The 6 feet is what's recommended. If you can maintain even further, that's even better, because you're outside, that virus is blowing around, which is what I think happened to my friend when he went to a socially distant family reunion. I think that virus was either blowing around from somebody within his family, or maybe somebody had been in the park and it was just kind of in the air, which really makes it awfully inconvenient for everyone. Try to have people, no hugging, no kissing, no touching each other. That's going to be very important. If you can wear a mask, wear a mask. I hope that the other people will be wearing a mask. And so, just, do all the standard precautions. Hand sanitizer. You're outdoors, so you might not have access to running water. So be sure and use the hand sanitizer and just use it frequently. There's another question that has popped in here about should I be screened for COVID? I've started going to therapy again. I have no symptoms. Well, the screening is generally for people who've had exposure to it or think they've had exposure to it. I would imagine in the therapy setting, it's probably they're probably doing very strict precautions there. I know when I go to my hospital setting for tests or doctor's visits, very strict. Even to walk into the facility, they usually take your temperature to see if you have the fever. Now, you can be carrying the COVID and not have a temperature yet, so you can have it in your body before you show symptoms. But I'm sure they're monitoring their staff. I'm sure areas are being wiped down even more so than they were in between patients. I'm sure the therapists are washing their hands. They should be wearing a mask when they're treating you. Some people will even want to use a face shield. I'm immunocompromised. I don't have a spinal cord injury, but I have the immunocompromised. So I was finally able to get some face shields. Whoa, baby, those are hot, just so you know. Those are really warm on your face. But, I feel it's very important to protect myself. So, if you want to use one of those, that's also a good idea as well. When you come home from therapy, be sure and wash your hands. Use the hand sanitizer, wash your hands before you leave, when you get in the car, and then when you get into your house. If you are able to change clothes, wipe down your wheels with your wheelchair wheels with disinfectant wipes. If you don't have disinfectant wipes, you can make your own, paper towel with a little soap and water or some bleach. As long as you're using friction, that is very beneficial because that dislodges the virus and can help, swish it away as you're wiping. The disinfectant wipes that have the bleach are really the best because that helps kill more germs. So those are the things that are going to be really critical to you as far as that goes. So we need to maintain our distance. We need to do the hand washing, wearing our mask if we can, and socially being distant from other people. If you're in an area where there is a lot of COVID and the cases are going up, that means that there's a lot more people just in the community where you live that are contagious or have it or it's being spread. One person spreads it to 8 people and then those 8 people spread it each to 8 people, so it can spread before the first person even has any symptoms. Places like a wedding where people are singing or where they're shouting, if they're at a game or if you're hollering hello to somebody across the way, that's a lot more force in your voice, and so that spreads the virus even a little bit further than just normal talking. So there's a lot of nuances to this, and it's really hard to maintain that safety. So just be cautious. I have to say congratulations to the bride and groom, though. My nephew got married about a little over a month ago, and we watched it on the computer. They had a few people at the wedding because they could congregate in groups of 10 or less. So the bridesmaids and groomsmen were there and the families were there, but family members like me that were once removed, the aunt, we stayed home. So it's been a real challenge, and life goes on, and there are a lot of life events that people are having to adapt, and it's really just kind of a stinky time. But it's going to resolve. There are a lot of people that are out there making those vaccines for this. I know of at least 57 different laboratories, and I'm sure there's more than that, but that's around the world. There are 57 laboratories. Some are going to the phase 3 clinical trials. Clinical trials go in 3 phases. Phase 1 is just to see if the vaccine is safe. Phase 2 is to try it in a small group of people. It's usually about 10 to 12 people, but can be as high as 50. And then phase 3 is where they give the vaccine to thousands of people, at least 1,000 or 2,000, and it sounds like in one trial, they're going to give it to 30,000 people to see what the side effects are. Now, those people that are trying the vaccine are people who don't really have any risk factors. And the risk factor doesn't mean you have a higher chance of getting it. The risk factor is that if you get it, you'll probably have a worse course. There are probably other risk factors out there that are still unknown. Again, like I say, it's all on shifting sand, so they've added more risk factors. So, but there are these people working on the vaccines. Now, there are a couple of vaccines that they're doing a completely different process. We know about the flu vaccine that we get, and we know we get vaccines for polio and all these kind of diseases that a lot of people think polio, smallpox. A lot of people think that these viruses are gone because people don't really get that anymore. They don't get those viruses and they don't become sick from it. Well, that's a little bit of a convoluted thinking. Yes, people don't get it because they get inoculated, so they can't get it. The virus is still out there, and in different parts of the world, it's more prevalent than it is in the United States in some of these diseases. So, COVID will probably still be out there, but if enough people get inoculated against it, then we'll have a little bit of immunity built up. The immunity of the COVID is kind of a questionable kind of thing because they are saying the immunity does not last very long if you've had the COVID. But I keep thinking about viruses just in general, and your body builds, every time you get a cold or a flu, a bacteria or a virus especially, your body builds up immunities to it. When you get well, you have immunities to that. But those immunities aren't floating around 24/7 in your body. The body remembers how to make those natural antibodies that your body makes, and so your body stores that information. Some of those natural antibodies are stored in the spleen, and they're called into action when needed by the autonomic nervous system. And this is one of the issues with people who have spinal cord injury, is that the autonomic nervous system can't call up those natural antibodies as quickly as it could before, or the nervous system might not recognize that virus as quickly as it did before. And that's why people who have spinal cord injury are more susceptible to bacteria and viruses, because of that little bit of pokiness in the autonomic nervous system. Doesn't mean it's not working. It just means sometimes it's a little bit slower, and it's different for everybody. So there's no rhyme or reason like, oh, I have a higher injury, so it doesn't work as well as somebody with a lower injury. That could be a factor, but it might not necessarily be, because not only do you have the difference in your injury, but you have just difference in the way that the human body works from one person to another. So there's a lot of stuff going on there with that. So anyway, all of these people are working on these vaccines. There are a couple of people that are working on vaccines that's going to be a new approach. It's not new in that they've been working on this approach for years and years and years. They're planning to use this approach to modify the RNA in your body so that if the COVID virus would enter your body, it won't be able to enter your cells. Therefore, you won't be able to get sick. It'll just pass through your body naturally. So that's a little bit of a different. I'm real optimistic about that because that's the way that healthcare is going to go. And since they already had like 20 or plus years of research into this technique, they will continue to use this kind of technique in new treatments. So lots of things going on. So we'll have to see, even when the vaccine comes out, we'll have to see how people who have different issues in their body, for me, immunosuppression, I won't be able to take the vaccine until they've tried it on people with immunosuppression unless I get in a drug trial to do that. So enough about the COVID for now. If there's any questions, we'll get back to that. So we'll go through and talk about, I wanted to talk a little bit about autonomic dysreflexia and pain, which happens in people who have thoracic spinal cord injuries. Now, They used to say that people at T4, and then it moved down to kind of T6, that people with those injuries and above would have autonomic dysreflexia. But that's really been, they've done a lot more work in research in autonomic dysreflexia, and people as low as T10 sometimes have that. Now, why is that? Because you have an injury at a certain level, but that doesn't mean that the spinal cord above and below that level is not also affected in some way. Maybe it doesn't translate into loss of function, but maybe it's just affected and it's not quite processing that information quite right. So autonomic dysreflexia is the hallmark symptom is this pounding headache. So people learn the pounding headache symptom and they think, oh, if I have the other symptoms, of which there's a lot, stuffy nose, visual disturbances, slow heart rate, goosebumps, flushing of skin, a feeling of dread or doom. There's a lot of other symptoms, but people don't really learn those. They learn about the pounding headache, so they think, oh, I don't have the pounding headache, so I don't have autonomic dysreflexia. But you still could have it with some of these other symptoms. So through the Christopher and Dana Reeve Paralysis Center, there's a lot of information about that's available to you. There's the Paralysis Resource Center, which has information specialists that can answer, I'm sure, any question on earth. You can also direct a question to me through them. That's another way to get a hold of me. They have the peer mentors, which is very helpful to connect with other people in your community or to find information about healthcare providers or how to go to the movie theater in your community. They have lots of written information, but they also have these wallet cards. So if you think you might have autonomic dysreflexia, it's good to print off that wallet card because you can use that in an emergent situation. If you have an episode of autonomic dysreflexia, and maybe you never had one, but as we age, our bodies change, you have a spinal cord injury for a while, we're finding a lot of triggers now through use of computers. It's good to have that card with you so that you can hand it to the healthcare providers and they can know what the treatment is. There's references to the state-of-the-art articles so that if you go to the ER and you happen to get a care provider that's never cared for somebody with a spinal cord injury, here's all the information that they will need. Another thing in the treatment of AD that's going on right now is this thing called silent AD, where people don't have any of the symptoms at all. They just have their blood pressure elevates. Now, since we know that people have cardiac issues, some people, not everyone, has some cardiac issues over the long term of spinal cord injury, and a lot of people were thinking that it was just due to inactivity, not being able to get the heart rate up with activity. And yes, that probably is one of the sources of the problems, but it's probably another source of the problem is the silent AD, where the blood pressure is going up, it's going down, it's going all around the town, and the person doesn't even know that this is happening to them. So those cardiovascular changes through the AD could be affecting the heart. Another thing that AD can be affecting is pain, and we're just starting to make those links between AD and pain, and the fact that, again, when you have AD, that triggers this cardiac response because the message that there's a problem is not getting to the brain, but the body is reacting. It knows something's going on, so the nervous system just releases full barrel. We're just going to release all the energy we can to fix whatever this problem might be, and so the heart will slow down, or and you get all, that's where you get the flushing and the headache because so much blood now is going to pump up to your head because the vessels constrict, so you get a higher blood pressure, and that's where you get this pounding headache. But some of the same things that happen is when a person who has AD is the same things that happen when a person has neuropathic pain, and it's, again, the body's trying to get the message through that there's some pain going on here. So they're starting to make these leaps between the two, And this is all kind of newer information, and so there's going to be some newer treatments that are going to be coming out for neuropathic pain, which also will decrease the autonomic dysreflexia. So it's kind of nice when you see all of that symmetry coming together. It's, you kind of think, well, about time, but it has to. People have to sift through this and figure all this out. So anyway. There's a question here. This is going to shift the gears a little bit, but there's a person who has a coccyx sacrum pressure sore approximately 2.6 centimeters deep. They found out they have a Pseudomonas infection. Will this infection slow or stop the healing process? They're currently receiving negative pressure therapy, which is the wound vac. So if there's an infection in the wound, yes, that does slow the healing process. So you need to clean up the infection before you heal the wound. And because if the wound closes over and that infection is still in there, then it festers in there and becomes like a cyst pocket in there. So you have to clean out the wound before you can allow the healing. So in that way, yes, it does slow down. So there should be some kind of either an oral antibiotic that's being taken, an IV antibiotic that's being given, or some kind of topical antibiotic that's being put inside this infected wound. So there should be some kind of treatment for that. Now they're using that wound vac, which is a really nifty treatment for pressure ulcers, because what it does is it's like a little vacuum. It's a very slight vacuum because, the tissue inside the body is very delicate. You can only use these on open wounds. They developed these for post-surgical wounds that weren't healing. And then they thought, well, hey, we can use these on pressure injuries. So what it does is it's like this little suction hose that goes over. There's a piece of plastic, so there's an airtight seal over the wound itself. And then there's this pressure that's kind of always drawing debris out of this wound. So the bacteria, dead skin cells, it's kind of always drawing this debris, and it gives a real mild amount of suction on the wound, which causes the blood to draw to the area to hopefully stimulate some of that healing. So it will take a while. If you have a wound that is open, it always takes longer. And open wounds have a much higher risk of becoming infected. If the wound never opens, like you get a red spot, or in people who have darker pigmented skin, they might get a purple spot. Sometimes they might describe the spot as ashy looking if you have darker pigmented skin. So if it never opens, you have a lot less chance of getting an infection. You just don't want that infection to be going into the body, because you don't want it to go into more tissue, and you don't want it to get to the bone where it can travel all through your body system. So that sounds like a great treatment. And your wound care specialist, if you're on the VAC, I'm sure is giving you some kind of treatment, but it will slow down the healing. But once the wound's open, it does take quite a long time to heal those up. So you've got to get the infection cleaned out before the skin can close over. So let's see. We have a listener from New York City, so congratulations. You're doing so well with the COVID up there. And we have a listener from India. So if you want to just send in your question, then we'll be able to answer that for you. There's somebody who wanted to know, is this about caregiver issues? We can talk about that if you want. Here's a great question. What can we do to build up our immunity? And sorry if you've answered this question already. This is a great question. So the best way to build up your immunity is to maintain an extremely healthy diet, because that's where you're going to get all the nutrition that your body's going to need to function properly. So maintaining a healthy diet, drinking some fluids, so whatever is allowed within your bladder program. You don't want to go over that, but you can add a little fluid that helps hydrate the body. And so if the body has enough nutrients, that certainly helps the body function better, so that builds up your immune system. So staying as healthy as possible, exercising and moving your body is also another thing. If you smoke, you need to stop that. Now, that's one of the hardest things in the world to do. It's easy to say, but it's so hard to do because smoking the nicotine enters your body, and then your body craves that nicotine. So it's very, very hard to do. But there are treatments that are available to do that, and sometimes people have a hard time giving up the nicotine, and so they try different patches. They maybe go to therapy. They try different medications. Think, oh, this is not working. But it will work. Sometimes it just takes several attempts to get there. If you drink a lot of alcohol, you'll want to slow down with that. If you take recreational drugs, you want to see if you can slow down with that and, get off of those things as well, because that's robbing your body. When you have alcohol in your body, that's robbing the opportunity. It's very dehydrating, and so you don't really get the fluid and the foods that you need. Also, the nicotine will bond with your oxygen cells, so that prevents oxygen from entering into your body. So, maintaining a clean and healthy life. Boy, doesn't that sound kind of soapy, but that is really the best thing that you can do. So, eating healthy, drinking fluids, especially water, and providing exercise to your body, because your body craves exercise. Our body wants to move, even if we can feel that or if we don't feel that. But that's another thing. I'm going to go ahead and skip over here to the presenter chat, which it appears that I just turned off in some particular way. So I'll continue with the questions where we are. Okay, sorry about that. I'm not sure exactly what I did, but I'll try to figure it out here. Okay, let's see. The next person has a urinary tract infection, and amoxicillin doesn't seem to be working as well. Besides the SCI, she has Charcot-Marie tooth, and I can't take some medication. I think she's looking for something to take instead. Well, now this is the thing about bacteria, and UTIs come from bacteria. And so every time you take an antibiotic, that particular bacteria is going to try to teach itself to live despite the antibiotic. So bacteria and viruses change over time because they don't have brains, they don't think, and they can't reason this out. But bacteria and viruses, their whole point of being there is to survive. That's the only thing that they do. They want to survive. And so they mutate and become something else so that antibiotic doesn't work. So if you typically take amoxicillin for an infection, what's going to happen is over time it's just not going to work because the bacteria is going to learn how to work around that amoxicillin. Now, hopefully when you take the antibiotic, it's killed off all the bacteria, but sometimes one lingers in there, and then we have this problems. So the way to figure out what you should be taking instead is to have take a specimen of the urine, take it to the lab, have it tested, make sure that bacteria is in there. Then once they have the bacteria isolated, then they'll do what they call a culture and sensitivity. So they grow that bacteria for 2 days in a laboratory dish. And then once they identify specifically what kind of bacteria that is, there are certain antibiotics that treat different bacteria. So not all the antibiotics treat every kind of bacteria. So if you have a UTI and you're taking an antibiotic and you're not getting better, it's probably because you're on an antibiotic that doesn't treat that specific kind of bacteria. So that's the way to do it. And so it takes 48 hours for the culture and sensitivity to come back. So it will take a little while to figure out, but then they'll be able to figure out what antibiotic you can take that will kill that bacteria. The sooner you get on these infections, the easier they are to treat. So if you think, oh, I might have an infection, I think I have one, I'll try pushing fluids and see if it goes away, they don't work that way. You need to get on these right away because you need to take what they call the lowest level of antibiotics. The antibiotics come in generations. They come in first, second, third, and they're working on some fourth generation antibiotics. So the lowest level are the simplest. They treat the simplest bacteria. You know, it's like penicillin, amoxicillin, you know, the xylins, sulfas. Those will treat the most general. But a lot of times, especially with people who have chronic urinary tract infections or repeating urinary tract infections, the bacteria has learned to become something else, and so you have to take a higher level of antibiotic. Eventually, you can work yourself out of the generations of antibiotics, and then you have an infection that can't be treated with antibiotics. And that's what we're seeing in the world today, is that so many people have taken so many different antibiotics. Now, I'm not talking about people with spinal cord injury. I'm talking about the human race in general. People have taken, you know, they go to the doctor, I have a cough, oh, here's an antibiotic. Oh, I have a little fever, oh, here's an antibiotic. So the antibiotics have been handed out in the past so nonchalantly that some people are getting these infections, and this will not be the case with you with the UTI because you've been taking amoxicillin, so you just need a different antibiotic to treat the mutation here. But for people just in general, after having repeated infections and taking antibiotics, sometimes people run out of antibiotics to take. The bacteria is mutated into something that's not really been seen before. Now, this takes a long time to happen. So I don't want to be alarming people. I don't want you to think, oh, no, I shouldn't take an antibiotic because I have an infection. No, in this case, the best thing is as soon as you think you have an infection, start taking the antibiotic because you want to start with these lower level antibiotics. And that way you'll keep yourself safe from running into bigger problems later in life. Yes, the next question is, did I hear correctly that there's more than one strain of COVID-19, just like multiple strains of flu? Yes, that is true. In Britain, they have isolated 6 different strains of the COVID-19. So we know that there's at least 6 different mutations of this one virus out there, similar but slightly different. So now what will that mean for treatment? Will we have to have 6 different vaccines to treat these 6 different strains, or as the COVID keeps out in the world and keeps getting stronger, there will be more strains that will be discovered? And so yes, eventually it will be just like the flu, where there will be a lot of strains of it out there. But hopefully, once we get the vaccine, hopefully it will be able to treat multiple strains at one time. So maybe it will reach almost like, I would say like the heart of the COVID, and then that would be able to help, that we would only need to have the one vaccine, and that would take care of it. So hopefully so. So here's a great question. Why is it so difficult to get approval for a spouse to get paid as caregiver? The bane of our existence, right? So this person goes on to say they were highly trained to provide care to their husband when he came home from the hospital, which sounds like he went to a great rehab facility. He had a nurse who came in while I worked, and then the COVID, so she was laid off. She's already used up all of her leave of absence time, which happens when somebody has a traumatic catastrophe in their life. People tend to use up all their sick leave to take care of their person. In the meantime, the nursing care stopped to the COVID because she felt she could be putting her husband at risk. So the caregiver probably wasn't really heeding maybe all the risk factors, so that was probably a good thing. So now no nurse and no income. We could lose our home. I'm the best choice to provide care for my husband, would actually save the state money. It's very frustrating to get answers. Yes, this is just a problem that persists because a lot of people are sent home. They don't even have the opportunity to have a nurse in their home, but they're sent home and it's like, here, have your family take care of you. Well, families work, and sometimes there's not a lot of extended family. Sometimes there's not people who are willing, or for some other reason they're not able to do the physical care that is required for some people. And everything gets in this tight bind, and this is a common issue. Now, there are there's this one place I've heard of in St. Louis called Deer Valley, and they say that they can get you hired as a caregiver and get payment, but it's minimum wage. So it might not be the amount of money that you still need to survive in your existing financial situation. But there are some places where you can get hired on at different agencies. You're working for the agency but providing the care. Now, Medicaid and Medicare don't usually pay for family members who are providing the care. Sometimes they do, but not usually, because they just think, well, you're all there together, that's your responsibility. So this is a political question, and I would love to have this brilliant answer of a workaround to how to make that happen. But the only thing I can suggest is that you can try applying for a job at a home health agency, and then see if the home health agency would be willing to, knowing that you're providing care for your husband. That's about the only way that I've seen it happen, and I've seen it happen so very infrequently. And I know from my own personal experience, my husband had a spinal cord injury, but from medical issues, not from trauma. And it was very frustrating because in looking at going on the Medicaid, then that meant that I would be on Medicaid as well. And I know that people have their spouses on Medicaid and they're not, but in our financial situation, I would be at home caring for my husband, and I would be in this exact same position that you're in. So I do know about this. I wrote to all of my congressmen asking them to please do something about this, and I just don't think we have a big enough voice to get anything moving about this, because in my financial situation, it was very much like your financial situation. If he went on Medicaid, then I would be having to give up my job. Anyway, it just is very, you hit home with me. So, Joanne, I really sympathize with this, but that is the only workaround that I have heard. Now, if he was getting home health, and it was just that this one nurse didn't want to come in, things are kind of clearing up now. Maybe you can start that up again, and so maybe you'll be able to go back to work, or, this COVID has just messed up everything. But even without the COVID, this is an issue that is going on. So talk to your healthcare professional. Say you need this help. You were allotted this health. Talk to your insurance case manager and say that you this help was required and you need this, and it shouldn't just stop because the COVID is here. And maybe you just need to find a different agency to have a different nurse come in and help, because that sounds like maybe it was one individual. So those are my suggestions for that. And good luck to you on that. And boy, we need to start a whole coalition about this, because this is just horrible for families. The next question is about dysautonomia, and a lot of the symptoms sound like the symptoms of AD sound like other things. And how do you know the difference? And the way that you know the difference is to take your blood pressure and find out if it goes up 20 points higher than your average, then you know you've got autonomic dysreflexia. Shortened, we just call it AD for short, because that's a mouthful to say. Okay, so that's how you know. But you have to know what your usual blood pressure is first. People with spinal cord injury, because they're not actively putting a lot of movement into their legs, they lose some of that power for their vessels in their legs to force the blood back up to the heart. So the blood pressure gets to be lower over time. So I know people who run around perfectly normal with a blood pressure of 80/40, spinal cord injury, especially the higher level, people with higher level injuries. So their blood pressures can be very low. 90/50 is not uncommon at all. Now, if your blood pressure goes up 20 points, that would be like 110/50. And so if you would go to the emergency room and say, I think I'm having an episode of autonomic dysreflexia, they would take your blood pressure and they would say, no, you've got a great blood pressure, because in society that would be a terrific blood pressure. But for a person with spinal cord injury, if it goes 20 points over their usual number, they can still be in the range of normal, but it's way too high for them. So the blood pressure is the key on making that diagnosis. Now, I've got a person who's written in, the lady from India, and she would love to talk. But in this particular mode that we have on this computer platform, you need to write in your question. And so if you could just write in that, that would be great. If we have different shoes for house, what happens when you go with different shoes in car? That's interesting. In your car, you're going to be stepping in and out from the outside. If you're not walking, you don't really need to change your shoes. You need to wash your rims. But if you're able to walk, if you use crutches or a walker or use some other kind of mobility device, you need to change your shoes from the outside to your house. So in your car, there's still going to be, you're going to be bringing in all kinds of bacteria or whatever from walking around outside. So that bottom of your car where your shoes go, that's going to remain a dirty spot until that gets cleaned out. But you don't want it in your home where you're going to be most of the time. So that's what the difference is, because you're going to be in that house breathing in things more. If you're outside, you would want to, where you're in your car, you might want to wear your mask if you're able to do that. The next question is, can a pressure sore be detected before there's any skin discoloration? That is a very good question, and usually the skin discoloration is the hallmark that a pressure sore is coming. So you need to check your skin very frequently to look for that discoloration, because if you catch it early enough, you can stay off that area, let the discoloration resolve, but then you need to monitor when you're in that particular area again. So like if you're laying on your side and you get discoloration on your hip in bed and you stay off of it, okay, it resolves, then when you lay on that side again, check it every 15 minutes to see how quickly it's coming back. Also be sure that you're using medical-grade equipment for seating and laying down. Some people will use pillows and foam that they get at the craft store because those are cushy. Right? Wrong. They are not. When you sit on that just regular grade foam, like on your couch, or if you use a pillow, a lot of times people like to sit on a pillow because it's more cushy. But what happens is that collapses. Pillows and regular foam collapses, creating more pressure on those pressure areas. So you need to use medical grade that will support the body and then disperse the pressure around the bony prominences. So sometimes there might be, if you're getting, because the pressure injury starts from inside the body closer to the bone, and so you might not see it on the surface of your skin, so you might have an increase in spasms. If you have some neuropathic pain, it might set off that. Those are about the two things. Sometimes if there's an infection that came from within your body that's creating a pressure injury, You might have some a fever from that, but it's usually the infection comes from the open sore rather than coming from inside the body, although it does happen. Sometimes people get cysts or fluid collections in there and it can get infected. So those might be some of the other ways that you might find out. Let's see. Some new therapies for neuropathic pain. A good friend of mine, so much pain. Can you touch on some other upcoming things that might help it or give me some resources to read? Yes. If you Google neuropathic pain, you'll be able to read the latest medical journal articles that have come up. The government runs a site called PubMed. So if you Google and you go into PubMed and then type in neuropathic pain, that's where all the latest research is going to be. Now, there's also another place where you can get some more cutting edge kind of things, because PubMed's going to be journal articles of things that have already been published. So it's research that's already been conducted. Another neat place to look is to go to a government site called Clinical Trials, one word, clinicaltrials.gov. And then you can search in there neuropathic pain. Any trial, any clinical trial that's coming up or recruiting or in process, or even one that's just recently closed but the information has not yet been published yet, will be on that site. So that's where you're going to get the most cutting-edge information. Now, that doesn't mean you're going to participate in one of those clinical trials. It might not be close enough to you. You might not be able to travel. Maybe, they'll have the inclusion-exclusion criteria. Maybe you don't qualify. But that's where they're going to have the latest things that are being studied is in that clinicaltrials.gov. So you can look at that information and discuss with your doctor. So there's some different thoughts on some different medications. Maybe you can't go in that clinical trial, but maybe you can take that medication off label, which you have to have agreement with your doctor. Maybe you can read about the clinical trial. Oh, yes, I would be in the inclusion criteria. I meet this qualifications, but it's on the other side of the country, or it's even, 50 miles away and I cannot get there for some odd reason. So that's really a place where you can get a lot of information about new and upcoming treatments. Here's a T5, and I don't qualify for a caregiver, and I'm having some severe GI issues. I'm not able to do my bowel program efficiently. What shall I do? My body is so painful and toxic. Well, you need to talk to your healthcare provider, because T5 is most people with T5 are able to do their bowel program, but maybe you need some additional equipment. Maybe if you've been trying to do it in bed, it's much harder to do effective bowel program when you're laying down. Sitting up using the effect of gravity is very, very helpful. And so that might be a thing that you can try. There's also, if you're having problems with pain, there's definitely some medications that you can use. There's some medications that, some lidocaine-like preparations that are made for the rectum that can be used to help eliminate that pain. If the stool is soft or if it's difficult to come out, you might want to try some fiber. If it's too loose, you might want to try, again, some fiber to bulk it up. Adding fluids, using different kinds of vegetables, adding roughage to your diet, that certainly helps. It's very difficult to master a bowel program. People think, you put the suppository in, you do some dig stim, bingo bango, it's done. It is never like that. There are some people who have no problem whatsoever, and good for them. They're the lucky ones, I guess. I don't know. But for some people, they just have a bowel that just seems to click in and go. For most people with spinal cord injury, their bowel slows down after spinal cord injury. Again, it's those autonomic nervous system functions that just kind of slow down, so the bowel is not moving as quickly as it used to. So there might be some medications to take to soften the stool, to coat the stool to come out more easily, to bulk up the stool. Taking some fiber certainly helps just about everybody. Also at the T5 level, there's a thing called a suppository inserter, which is not really too awfully expensive, but your insurance should be able to pay for that. And that's helpful to get the suppository in and up high enough. The suppository has to be put in really the length of the entire finger, and sometimes it's kind of hard to wibble around a commode and get that suppository in high enough. That's where the internal sphincter is. That's the sphincter that needs to relax to release the bowel, the stool. The external sphincter is the rectum, and a lot of people think, okay, I've got that, I've stimulated that, it's dilated now, but the internal sphincter is not. Also at the thoracic level, people with thoracic and cervical injuries tend to have more spasticity. So your bowel might be spastic. Maybe you don't see it in your legs. Maybe your legs are not, but maybe your bowel is. So treatment for spasticity might also help. Some people do their bowel program too aggressively because they want to get in and get out quick. It's not the kind of thing where people are like, oh, goody, I get to do a bowel program today. It's just a matter of fact. These are just the way that, stool is eliminated from the body for some people, and so it has to be done. So really taking your time and being very gentle with the digital stimulation, because the digital stimulation can trigger the spasticity, which makes it even more difficult and painful to remove that. So those are some suggestions, and I'm not saying that these are any of your issues, but I'm just trying to run the whole gamut of issues for everybody. But it sounds like if you're having all these GI problems that you really need to talk to your healthcare professional and see. Most people do their bowel program every other day. Some people do it every third day. It's really not a good thing. It's okay for that very, very small number of people, but really every other day is kind of the thing that most people are satisfied with. Some people need to do their bowel program every day. Maybe your gut works faster than the average person, and so some people really need to do their bowel program every day, do that evacuation, and that kind of takes away some of that tension in the bowel. If the stool is very hard, you need to soften it in some way. And then do the bowel program at the same time every day. Years ago, they used to call it bowel training instead of a bowel program, and that was really a very applicable word because you're training the bowel that it's going to store the stool until this particular time every day. And over time, your bowel actually learns to do that. And so some people actually eliminate the suppository and they just do the dig stim, they evacuate, and they're on their way. So your bowel does learn. You do train your bowel, but it has to be done approximately the same time every single day. Now, if you're having some problems with the cramping issues, some people find better luck with a glycerin suppository. That is not as severe as the Ducalox or the Magic Bullet suppository. The Ducalox and the Magic Bullet suppository are actually the same chemical compound. Is that the Ducalox suppository has a coating that has to dissolve, and the Magic Bullet does not have that coating. So some people find the Magic Bullet to be too caustic. Some people find the Ducalox with the coating to be too caustic. So that's another thing. The suppository has to go up against the bowel to work because it's the body heat that makes the suppository melt, and then that medicine floods the lower part of the bowel, so it stimulates those little fibers inside the bowel and the muscle contractions to work. And so that's the way all of that works. So sometimes people get too much stimulation and they have too much cramping. Sometimes people need a stronger suppository. Now, you don't want to turn to the enema because that flushes out the whole bowel, so the bowel isn't working, and after a while the bowel will stop working if you get into chronic enema use. There is one little enema. It's called the mini enema, the enemies, and it's just a little bitty tiny bit of enema solution that gets inserted into the bowel. And so some people find better luck with that. So there are some options for you. So I can see we're at the top of the hour, so it's time for me to stop. I hope I provided some information for you that will be helpful. Now, if you would like to have more information, or if you have a specific question that maybe you don't want to ask while everybody's listening, that's fine too. You can get in contact with me. I'm on the community through the Christopher and Dana Reeve website. There's a little inbox, and you can send a message to me directly, or you can talk to the information specialist at the Paralysis Resource Center. They can contact me. And so if you have something that else you want to talk about, I will be on between 7 and 8 tonight Central Time, as I am every Wednesday night. So stay safe out there. Watch for the COVID virus. Keep yourself healthy. And I'll talk to you again next month.